All right, everybody. Now that we're at 5:01, I think it's safe to get started. Welcome, everyone, to JACC Journal Club. We're very excited for today's session on novel treatments for TTR amyloidosis. Dr. Coley and I will be the ones orchestrating the session, and we'll introduce our panelists in a few minutes. For those who don't know, JACC Journal Club is something new that we've been doing where we talk about interesting topics based on recent JACC publications featuring both authors and editors of these publications. It's been a lot of fun, and we're very excited for today's session. I'm also happy to announce that as of recently, this is a CME accredited activity. So attending this activity will qualify you for CME credit. As a requirement of CME credit, I will be showing a bunch of slides on the screen in rapid succession. I will not be reading them, but they are available for your review. Here is the statement of need. This is the overall goal and target audience. Our learning objectives are listed here. Credit statements for various interprofessional societies. This is our disclaimer statement. Disclosures and conflicts of interest. And here are the disclosures for the planners of JACC Journal Club, followed by disclosures for our faculty for today. A few more slides about CME. Okay. So with that out of the way, now we get to talk about the fun stuff. So we will be discussing two articles about TTR amyloidosis that were recently published in JACC, dealing with two novel treatments. The first one is early increase in serum transthyretin by Acoramidis. I hope I'm saying that right. And the second is impact of heart failure severity on Vutrisiran, which is even harder for me to say. These are both articles that were recently published in JACC. The QR codes here will link to the JACC publication. So if you would like on your phone, I'm going to stall for a few seconds here. If you want to scan the QR codes, this will pop up the link. Both of these articles are published and available online. You can also just Google them anytime, and you'll get the full manuscript, which you can pull up as we are talking. We're very fortunate for today's panel to have our two panelists join us. Panelist number one is Dr. Matthew Maurer, who, for those who don't recognize the name, Dr. Matthew Maurer, he's a heart failure cardiologist at Columbia, and probably the person in the world who knows the most about TTR amyloidosis. He's senior author on both, first author on both of the publications that we'll be discussing today, as well as on innumerable other such publications about TTR amyloidosis. So we're very happy to have Dr. Maurer. Thank you very much and welcome.
My pleasure to be here. Thanks.
And our second panelist is Dr. Michelle Kittleson, who is a heart failure cardiologist at Cedars-Sinai. For the purposes of this discussion, I also have to tell you she is an associate editor for JACC and has been involved in reviewing a lot of the publications that have been relevant to heart failure and amyloidosis. Also very, very popular in the online medical world. And we're very happy to have you. Thank you very much for being here.
Thank you so much.
Okay, so before we get started with the actual content, just a review of what we're going to do. We're going to spend a few minutes talking about overview of TTR amyloid pathophysiology and treatments. We're going to have a very rapid summary of the top-line trials, ATTRibute-CM and HELIOS-B. Both of those were not published in JACC, but the papers we'll be discussing today are sub-studies of those, so we'll have a very brief review of those. Then we'll have a deep dive discussion into the two JACC papers that we'll be discussing, followed by a discussion of interesting topics with our expert panelists. And if you're here today, we will also welcome your questions in the chat. So what I would encourage you to do is, as we go along, type in your questions in the chat as we go. If you'd like to address them to a specific panelist, feel free. If not, you don't have to. My only request is before typing in a question, please change your name in Zoom to include the following information: your name, your training level, and the state you're in the US, or the country you're in if you're not in the US. I gave my example here below. This is just helpful for our team on the back end to track who's participating, who's asking questions, and we use this data after the fact. Okay, so we're going to start off with a question. Hopefully this will be built into Zoom. How many disease-specific treatments are FDA approved for the treatment of TTR cardiac amyloidosis as of today, May 21st, 2025? So it should pop up automatically in Zoom for you to fill out this poll. We'll give it about 10 seconds and then we'll close the poll. Okay, why don't we go ahead and close the poll and then we'll see what our results are. Okay, so by the end, a nice little spread here. By the end of our talk, we'll figure out what the right answer is. I'm going to leave you in suspense for now. And we'll move on to question number 2, which is true or false? All disease-specific FDA-approved therapies for TTR amyloidosis have the same mechanism of action. So again, if we could open our Zoom poll for that. Give it about 10 seconds. All right, let's go ahead and close the poll. Okay, you guys are good test takers. There you go. All right, so with that out of the way, we can get started with the bulk of the talk. I am going to hand it over to my colleague, Dr. Coley, who will take over to get started.
Great, thanks everyone. Before we get too deep into our articles for today, I want to do a quick review of what exactly happens with TTR amyloid. So TTR protein is produced normally by the liver, and they form these TTR tetramers. That's their shape. But what happens in TTR amyloid is that those tetramers dissociate. They fold into these dimers and monomers, and eventually they become these amyloid fibrils, which just deposit into the heart and the nerves, causing the disease that we see in clinic. Next slide. So the therapies that we're going to be talking today and that you've been hearing about sort of target amyloid at various parts of the process of the formation of those fibrils. So first are the TTR gene silencers. So the one we're going to be talking about today is Vutrisiran. It specifically targets the mRNA so that the TTR is not produced. Then we have TTR stabilizers, which we have Tafamidis and Acoramidis. And what they do is stabilize the protein in that tetramer form so that they don't start dissociating. Acoramidis is thought to be a more complete stabilizer of these tetramers than Tafamidis, so it's a little bit stronger in its effect. And then finally, there will be a class of drugs that we'll hopefully hear more about in the future, amyloid fibril disruptors, which will actually get into the amyloid fibril that's already deposited into the heart and the nerves and get rid of it so that the heart can recover. Next slide. I just wanted to quick include this NACC staging review because we'll see that in one of the studies as a way to predict mortality or events in patients with amyloid. This is published in 2018. It's from the UK National Amyloid Center. The study looked at predictors of mortality in over 800 patients with ATTR cardiomyopathy. And ultimately, the staging is based on two pretty readily and easily available labs that we get in all our patients. So patients are broken up into stages by their NT-proBNP level and their GFR level, and those stages do correspond with different levels of survival. Next slide. So as Dr. Kulkarni mentioned, the studies that we're talking about today are sub-studies of two larger TTR amyloid studies that were done previously. The first one is ATTRibute-CM. This is a study that specifically looked at Acoramidis. It's a phase 3 double-blind randomized control trial that evaluated the efficacy and safety of Acoramidis. Patients included were those that were 18 to 90 years old, and they had established diagnosis of TTR amyloid either by an endomyocardial biopsy or a PYP, and they had some sign of clinical heart failure, whether that was hospitalization or use of diuretics. Ultimately, the study included 632 patients that were randomly assigned in a 2-to-1 ratio to receive Acoramidis 800 milligrams. It's twice-a-day dosing or placebo for 30 months. Next slide, please. And the outcomes really favored treatment with Acoramidis. Patients who were treated with Acoramidis were less likely to have death from any cause, cardiovascular-related hospitalization, and lower levels of NT-proBNP, while they also had greater 6-minute walk distance test results at the end of the study period. Next slide. Helios-B is a study that looked specifically at Vutrisiran. I also have a difficulty saying that one. It's a phase 3 double-blind randomized placebo-controlled trial. In this trial, 655 patients were assigned in a 1-to-1 ratio to receive Vutrisiran or placebo every 12 weeks. It's an injection for up to 36 months. Similarly, included in this study were 18 to 85 years old with a diagnosis of TTR cardiomyopathy. They had to have findings of amyloid on echo and a clinical history of heart failure. Next slide. And again, similar to Acoramidis, the patients treated with Vutrisiran did better than those treated with placebo. They were less likely to have death from any cause and any recurrent cardiovascular events. Next slide. So going into our first study, early increase in serum TTR by Acoramidis independently predicts improved survival in TTR amyloid cardiomyopathy. Next slide. So in the original study, ATTRibute-CM, the stabilization of that TTR prealbumin by Acoramidis resulted in an immediate and sustained rise in serum TTR. They were able to measure that in the blood. So the question asked in this sub-study was, can these serum TTR levels be used as a biomarker to guide treatment? And are serum TTR levels associated with all-cause mortality? Next slide.
Before we move on, I was just hoping to ask a question here for Dr. Maurer. Is tafamidis is the agent that I think most of us are familiar with, and is measuring TTR levels or prealbumin levels, is this something that is typically being done in patients who are being treated with tafamidis?
At our center, it is. I don't know about everywhere else. I mean, we've been obviously interested in, I'd say, responding to patients' questions in the clinic. Patients often ask, "Hey, I took this drug. I don't feel any different. How do you know it's working?" And we wrote, and Rodney Falk wrote papers a few years ago showing that in response to a stabilizer, in this case tafamidis, the TTR levels rise. They go up more in patients who have variant disease than wild type, probably because they start lower, and they probably more unstable, and they go up more, interestingly, in women than in men. But all those studies were just descriptive and kind of underpowered to look at outcomes. But yeah, so we've been measuring, and I think many amyloid centers do measure this over time. TTR, by the way, is also known as prealbumin, right? That's the original name for it, because toot Columbia's horn, when it was discovered in 1970 in DeWitt Goodman's lab here at Columbia, across the street from my office. They didn't have any way to characterize proteins except by electrophoresis, and they basically separated proteins in size order, like a kindergarten picture, tallest to shortest, and this protein showed up in size before albumin. So that's how it got its original name, and when you measure it in clinic, you order a prealbumin level. But we've renamed it appropriately Transthyretin because it transports thyroid hormone and retinol. So synonymous ideas, but a very easy to measure biomarker. Obviously, surgeons have measured it for years as kind of a nutritional biomarker, and it's got negative acute phase reactance. So if you get sick, your prealbumin levels go down. So there are a bunch of confounders in all of this, but hope that answers the question.
And I'm curious, Dr. Kittleson, as somebody who is not limited in their practice to amyloid, do you also find yourself using this a lot clinically?
So Dr. Maurer and I have had this discussion many, many times. There's no question that it will go up when you give a stabilizer. However, the question for me is, how does that change my management? So when you're checking it routinely in a patient in clinic, whether it's, I don't know, right after starting it on a yearly basis, whatever, I don't know what I'm supposed to do with that information. So being an extreme minimalist as my physician temperament, I have not checked it, though I am hopeful that based as this study as a foundation may someday allow us to use that information to guide decisions.
Thank you for that wonderful segue. Back to Dr. Coley.
Great, thank you. So the study designed for this sub-study was at serum TTR levels from 557 patients with known TTR cardiomyopathy from that original ATTRibute-CM study population were evaluated. 372 were on Acoramidis and 185 were on placebo. They collected the blood samples at baseline and then 1 hour post-dose at day 28. Then they collected samples every 3 months through month 30. And then with that data, they did a couple of statistical analyses, including univariate and multivariate modeling, to evaluate any factors that were associated with all-cause mortality. Next slide. So you can see that the baseline demographics of both the placebo and the Acoramidis group were fairly similar. It's an older population, mostly male, mostly wild-type TTR patients. The majority of the patients in the study had NYHA2 class symptoms. There were fewer patients in the class 1 and class 3 groups. Their NT-proBNPs were, above 2,300 in all the groups, and the GFR was generally around 60. Next slide. And ultimately, what we found is that the change in baseline serum TTR level did go up as patients were treated with Acoramidis. You can see that it went up almost pretty much immediately at day 28, and that increase was sustained through the 30-month period. On the graph on the right side of the screen is called a waterfall plot, and that is the change in the TTR that patients had between day 0 and day 28, and that's represented by the bars in that graph. And so red represents the patients in placebo, and blue represents the patients that received treatment with Acoramidis. And you can see that if you were on placebo, you either had a drop in your TTR within that first month, or you stayed kind of stable, even. But you'll see that the blue group, the Acoramidis group, pretty much went up at day 28. Next slide, please.
I'm curious, Dr. Maurer. Waterfall plots have been a big focus of JACC recently, and I'm curious that there are some patients who got the drug whose TTR levels did not change appropriately, did not increase appropriately, and similarly, there are a few placebo patients whose levels did go up. Do you think these deviations are related to the fact that it's a negative acute phase reactant, or do you think there's some other mechanism happening here? How do we explain that?
Yeah, I think waterfall plots are great, and you're pointing out an important thing, which is don't always go with the flow with everybody, but look for the outliers. I think it's quite possible that many of the patients who even got drug who declined may have had an intercurrent event or something that drove down their TTR, like you're pointing out, as a negative acute phase reactant. I wonder if some of the quote-unquote placebo patients were taking diflunisal, another TTR stabilizer that could increase their levels. This will get back to Michelle's important point, which is when we go through the data, population level data is quite suggestive of an effect. But taking population level data and sitting in front of a patient in clinic is a totally different thing. So as an example, we have some patient who advocated for switching recently from one stabilizer to another, and because we're sensitive to their needs, we did it. And now he's upset that his TTR levels didn't go up. And I kind of had to take him off the ledge, so to speak. So, these are suggestive biomarkers, but I think I have to apply them carefully and cautiously in clinic.
Thank you. Yeah. Dr. Coley?
Let's see. So moving on to the survival curves in the Acoramidis versus placebo groups, you can see that, again, blue here represents patients who had a serum TTR level greater than or equal to 20. The groups were stratified based on these levels. And red represents a serum TTR level less than 20 milligrams per deciliter. And this is the baseline STTR level. And you can see that if you started with a higher STTR level, you had a better survival at that month 30 than if you had a STTR level less than 20 at that time. They also looked at the change in TTR. So if you quickly change your TTR either up or down, that could also predict survival. And you can see that the early delta of TTR and that sort of jumping quartiles at a higher level, those patients had, again, higher survival than all of the other quartiles that you can see here. And so ultimately, it was shown that higher baseline serum TTR and higher early change in TTR were associated with improved survival.
I would just point out those hazard ratios are per milligram per deciliter, so very small changes in this report here. There are obviously other reports where much larger changes associated with greater risk reduction, but this is per milligram per deciliter, very tiny, 20 to 21. We're talking about 21 to 22.
And then what's shown here are logistic modeling plots where you can see the probability of all-cause mortality as a function of that change, that early change in serum TTR levels through month 30. And what you can see is that if you have a higher change in your TTR from that day 0 to your baseline TTR to day 28, again, your survival, your likelihood of all-cause mortality is lower, and that is shown really in panel B. You can see what a dramatic change it makes in that Acoramidis group. So the study limitations were that the population may not accurately reflect all of the general populations. From the larger study, only participants with available baseline and day 20 serum TTR levels were included. So this was not the entire population from ATTR-CM. This data may not be generalizable to all TTR stabilizers, and there was no combination therapy used here. So patients were only on placebo or only on Acoramidis. And the key findings, again, higher levels of baseline serum TTR are associated with improved survival, and that early change in TTR is associated with improved survival. So for every 5 milligrams per deciliter increase in serum TTR, there was a 31.6% reduction in odds of death and 26.6% reduction in risk of death.
Thank you, Dr. Coley. Now, before we get into a detailed discussion about that article, I'll let Dr. Coley introduce the second one. I think if everybody could put their questions into the chat, and then we'll go through our second article and then bring everything together at the end. So go ahead, Dr. Coley.
Great, thank you. So this is the second study. This again was a sub-study of the Helios-B trial. This is impact of heart failure severity on Vutrisiran, Efficacy, and Transthyretin amyloidosis with cardiomyopathy. Next slide. So the study question here was, does the treatment effect of Vutrisiran vary with baseline disease severity? So if you have worse heart failure or worse, again, NAC stage, for instance, will that treatment effect change? Next slide. Again, the study design here is that 655 patients from the Helios-B study were included. The patients were all stratified according to their baseline functional capacity. So they used NYHA classes 1, 2, and 3, and NT-proBNP levels of less than or equal to 200 or greater than 200. Patients in this study could be on tafamidis, so that is one thing to keep in mind. And the outcomes looked at were all-cause mortality and recurrent cardiovascular events during the 36-month follow-up period. Next slide. So these are the baseline characteristics of the groups. So initially they were divided. We divided the groups into, again, if they got treatment versus placebo, and then stratified that by what their baseline NYHA functional class was. That's the panel on the left. The groups are largely similar between NYHA 1, 2, and 3, except for their use of tafamidis. As you'll notice, it's the white line in the middle of the screen. There was higher tafamidis use in the stage 1 group, it looks like, compared to, it's our NYHA class 1 compared to NYHA class 2. So there was some difference there. But otherwise, the findings are largely pretty much similar in terms of baseline demographics. And same when you stratify the groups by that baseline NT-proBNP, the differences are very minimal. And next slide. And they further looked at the baseline characteristics of just people who were on Vutrisiran. So they went ahead and took out the people on tafamidis. And again, the findings for each group are largely similar, except that there were some, what you see is that the measures of functional capacity worsen as the BNP goes up and as the NYHA class gets worse. And you do see that the NT-proBNP goes up as NYHA class increases. So again, findings that are consistent with what you would think. Next slide. And again, the outcomes here really suggests that vutrisiran is beneficial for outcomes of all-cause mortality and recurrent CV events, and when you stratify by functional class and when you stratify by NT-proBNP. And especially what's striking is that the healthier you are, like if your NYHA functional class 1 or your NT-proBNP was less than or equal to 2,000, you were even more likely to get that benefit from vutrisiran in terms of those events. And that applied in both the overall population and the monotherapy population. Next slide. And here's another look at the outcomes, this time also stratified by baseline heart failure severity using some other measures, including Columbia stage and that NAC stage that I showed in the beginning slides. And again, there was an improvement in all-cause mortality and recurrent CV events in the treated population versus the non-treated population. And that also applied when there was just Acoramidis monotherapy. Next slide. So the limitations of this study, patients with NYHA class 4 and NYHA class 3 plus NAC3 were excluded. So the sickest patients are not in this trial. The number of NYHA 1 and NYHA 3 patients was small. Most of them were NYHA 2. And the original study didn't randomize according to these subgroups. This was something that was done after the original study was completed. Next slide. So the key findings, vutrisiran decreased the risk of all-cause mortality and cardiovascular events across heart failure subgroups. Benefits were greatest in patients with earlier and less severe disease. And so that's a population that may benefit the most. Next slide. And then we have a couple of discussions.
Yeah, thank you, Dr. Coley, for going through all of that. We, there's a lot that we could potentially talk about all of these articles. And so we tried to put together some questions that would start off the discussion, but please, as you have questions that are coming up, please enter them into the chat. We'll deal with the chat-based questions later. I guess for the first question, I'll start off by asking Dr. Maurer, how do we approach initial treatment of TTR amyloid now that there are 3 therapies? That was the answer to the question before: tafamidis, Acoramidis, and Vutrisiran, which I still don't know if I'm saying it right. How do we think about what to do and how to approach a patient, brand new diagnosis of TTR? Where do we start?
Yeah, it's a great and unanswerable question, in my opinion. We have 3 robust late phase randomized clinical trials that show all 3 agents work, but we have little to no comparative data. And so I think we're in a data-free zone. It's a very ripe area for additional investigation. We may learn more from upcoming clinical trials. But at this point in time, I think the right approach is to honestly admit to people we don't know and describe to them the different therapies. And in my clinical experience caring for a lot of these patients, they're a little disappointed when they hear we don't know the answer, but they ultimately accept that. And then there are nuances to how the drugs are administered: oral versus sub-Q, once a day versus twice a day, need for concomitant vitamin A therapy, having to come to a healthcare facility a few times a year. And people often, I think at this point, make decisions in that regard based on those, non-efficacy related things. So I think we'd encourage people to say your key here is to get a therapy that works. They all work, and get one as early as possible. So I wish I could give you a better answer, but that's my conclusion. Michelle, I don't know how you handle it.
And I was going to ask actually, Dr. Kittleson, if piggybacking off what he said, if you could also weigh in on how, as a non-amyloid limited practitioner, how you go about making these diagnoses, because obviously now that we have a lot of therapies, early diagnosis is critical. Do you think we're under testing? Do you think we're testing appropriately? Do you think everybody should get PYP scans? Tell us about that.
So to be fair, half of my heart failure practice is amyloid, so I do feel confident to answer that question, participating in many consensus documents on the topic with Dr. Maurer. But let me let me answer your diagnosis question, but I also want to give you my algorithm for treatment because I have an algorithm for everything. But starting with diagnosis, that's hugely important to have a high index of suspicion in the face of clinical clues. Dyspnea, edema, increased LV wall thickness. Already the hair on the back of your neck is tingling a little bit. You're like, something's going on. Remember, in case series, about 15% of patients with HFpEF, when tested, have underlying cardiac amyloidosis, most commonly TTR. And then in case series of older patients undergoing transcatheter aortic valve intervention for severe symptomatic AS have concomitant cardiac amyloidosis. So don't forget about it. So if someone has increased LV wall thickness, don't anchor on LVH. It might not be hypertrophy, it might be infiltration. So already you've got that context of the clinical clues, and then you add on the other stuff, the seemingly disparate findings that lead to a satisfying, unifying diagnosis, including, gosh, carpal tunnel later in life, that's kind of weird, bilateral over the age of 60, or lumbar spinal stenosis. What about a neuropathy? What about a family history? What about Black Americans, 3.4% of whom carry the V142I TTR variant that can lead to TTR cardiac amyloidosis? So all of these things become pattern recognition. There's also an awesome score put together by colleagues at the Mayo Clinic that you can look at from JAMA Cardiology. That's 6 clinical findings that can lead to increasing your pretest probability. But the bottom line is dyspnea, edema, older patient, and you've got this increased LV wall thickness and you're not exactly sure why. It can't be easily explained by hypertension. Then you have these other musculoskeletal, orthopedic, neurologic findings have a high index of suspicion. And remember, when you're going to diagnose it, you can't do just a technetium pyrophosphate scan because 10 to 20% of patients with AL cardiac amyloidosis can have a false positive technetium scan. So if you interpret it outside the context of a negative monoclonal protein screen, you can miss a diagnosis of AL cardiac amyloidosis, which untreated has a median survival of less than a year, and you don't want to kill your patient. So you start with the monoclonal protein screen. If negative, you celebrate and check your technetium pyrophosphate scan. If abnormal, the patient has bought themselves an endomyocardial biopsy. So those nuances of diagnosis are incredibly important. And can I go right into my treatment algorithm, or do you want to pause first?
Please go ahead.
So here's my treatment algorithm. As Dr. Maurer said, they all work, but you can't compare them head to head in trials because the trials, due to error effect, have enrolled vastly different patients. So the point estimates for the event rates are successively better in serial trials, even in the placebo group, compared to the treatment arm of the prior trials, because we're getting so much better at diagnosis and also heart failure management. We know none of these medications make you feel better because they don't reverse disease. They just slow the progression of feeling worse. So what do I tell patients? Like Dr. Maurer, master clinician, I tell them we have 3 medicines and they all work. I can't tell you which one works better. So I say to myself, number 1, are you too far gone to benefit? Are you NYHA class 4? Is your NT-proBNP 10,000? Are you bedridden? Is your kidney horrible? Are you really hypotensive? Maybe you're too far gone. Let's have that difficult discussion about futility of therapy. But if you're not, then do you have neuropathy? Because if you do, Vutrisiran and the silencers do have evidence of efficacy in neuropathy, decreasing progression. The stabilizers probably work too, but they haven't been tested in that area. So I'll probably say, you know what? Maybe a Vutrisiran is the best option for you. If they don't, then I might ask myself, does insurance have a preference? Shocking to me to date that insurance has not put up guardrails for any of these therapies, but I feel like that's coming, and that's okay because they all work. So whatever your insurance wants, it's cheaper for you. Let's give you that. And if they aren't too far gone, and they don't have neuropathy as a compelling secondary indication, and they don't have an insurance preference or cost preference, then I'll ask them, do you like a pill every day, a few pills a day, or do you like an infusion every 3 months? And so basically, as Dr. Maurer said, that's my stepwise algorithm to decide on therapy.
Yeah, thank you very much. You went into the second question I was going to ask, which is, should we change initial therapy based on disease severity or stage? Dr. Maurer, do you have any thoughts on that one?
I wanted to tie it back to the initial report. So as you pointed out on the waterfall plots, there are probably patients who may not respond to a stabilizer, and it could be those patients whose prealbumin or TTR levels don't go up very much. So an example, I have a patient I'm seeing tomorrow who's, in her 50s. She has an unusual variant, pretty bad cardiomyopathy, has been on a stabilizer for a while, and her prealbumin level, which, by the way, when you measure prealbumin in the office before you get your genotype back, is a pretty good marker of who's going to have variant disease or not. If you're heterozygous for V122I, your prealbumin levels, TTR levels, are usually in the range of about 15 or something, so below the 20. And if you're homozygous, they're usually below 10. And that's not always the case, but pretty good sign. And so her TTR hasn't budged in a year on therapy, and she's actually feeling worse. So those are nuances. That is a very rare patient, to be frank. So I don't think that the prealbumin change is going to be wildly making decisions. But in that particular case, I'm trying to get her a silencer. Again, her insurance, as Michelle points out, is presenting a lot of roadblocks, despite multiple appeals. I think Michelle makes a good point. There are people who are way past the pale, who don't benefit probably from these therapies at all. And we have to have an honest discussion with them about the fact that you have very advanced disease and you're probably going to live a smidge longer if you have class 4 NT-proBNPs of 10,000, but not in a state that they're going to enjoy. And I think when you explain that, probably most people would choose not to get therapy, though that varies in some regard. I think the other message from the analysis of the Helios B is that earlier is better. As Michelle points out, we're not at this point using depleters and removing amyloid. We're not reversing the phenotype. And what we learned from at least another trial, Apollo B, which did not lead to regulatory approval, but was a study of Vutrisiran, was that after patients received, God forbid, placebo for a year and declined, when we switched them over to active therapy, they stabilized, but whatever they lost, they didn't regain. And so, you need to, like the old adage, time is muscle, you need to intervene early here. So I would try to move us to, trying to find people earlier. Your question about, diagnosis, Michelle highlighted all the important things, but I do think we have to be very, very scrutinous with these tests that we've developed, in people who have advanced disease, and apply them to a population with a very low pretest probability. So if you start screening, 100 people and only going to find 5, I can assure you, you're going to find a lot more quote unquote false positives if you don't follow all the rules, which is screen people who have some suspicion for this condition, right? Not someone with a 9-centimeter ventricle and an EF of 10, even if they're elderly. Make sure you always assess monoclonal proteins, but that's irrespective. And I think you really need to start doing, scintigraphy with later imaging. So you eliminate blood pool and use a SPECT, or ideally SPECT CT imaging, because there could be very early disease that you'll miss if you just kind of don't follow what are the guidelines. So those are important things as we shift to an earlier stage of patients.
Great. Thank you very much. The next question I had, I think we may have touched on already, which is, does serum TTR have a clinical role in monitoring treatment? I think from what I've heard you guys mention, and please correct me if I'm wrong, it sounds like although it is not necessarily the case that checking levels will directly impact the decisions you make, it does give some insight into whether the patient may or may not be responding, whether another therapy may be appropriate. So maybe. Have I summarized that correctly?
Yeah, I think the maybe is the key word there. I don't think we know yet. I think the one other interesting unanswered question is, why did these levels go up? And the general assumption, a prevailing paradigm, not proven, is that we're shifting from less stable to more stable tetrameric TTR. I have to say, biochemists tell me that hypothesis is not proven, because the antibody that measures TTR is polyclonal, and it doesn't necessarily only measure intact tetramers. So what are the other possibilities? By stabilizing the protein, you might be prolonging its half-life. TTR lasts 2 or 3 days, but maybe it's lasting a little bit longer. You might, by stabilizing it, facilitate excretion out of hepatocytes in the endoplasmic reticulum, and so there could be an increase in levels in that regard. And it could be that there's, as we're thinking, a shift toward more tetrameric and less monomeric TTR. But I think we need to focus a little bit more with our basic science colleagues and provide them some samples on patients to actually figure out what does this increase truly represent, because we're making, I think at this point, probably appropriate assumptions given the outcome data. But at this point, I would say that's another area for someone who's interested for investigation, trying to figure out biochemically what's actually happening for monomers, oligomers, and tetramers.
Just to piggyback onto that, to emphasize the maybe, it is definitely a biomarker, but is it a biomarker as powerful as, for example, LDL cholesterol in the prevention of atherosclerotic cardiovascular disease, or free light chains in the treatment of multiple myeloma or AL amyloidosis? It's not there yet. And I think to presuppose a level of certainty on how you should dictate therapy based on levels, it does us, I think, and patients a disservice. So this is very exciting that a change in level does carry a prognostic impact, but we still don't know how titrating therapy to a change in level makes a difference.
And I would just add to Michelle's comment, we already have, 20 biomarkers in the clinic, right, about knowing what's going on with people. This seems to be, at least in this data set, context of a clinical trial, robustly collected, same laboratory, lots of other nuances independent of that, but we need to really see that in the real world, where the patient goes from your hospital to another hospital or another laboratory to get measured and see. I think the jury's out at this point in time.
Great. Thank you both very much. Now on to the next question, which as a general cardiologist in a regular old hospital, I'm very curious to hear your answer to, which is how can we ensure equitable access to these therapies? Unfortunately, to the best of my knowledge, all of these 3 FDA-approved therapies are wildly expensive. I know there are certain programs available and insurance rules and this and that, but practically speaking, I feel like I'm very good at making a diagnosis of TTR amyloid, and then it's an uphill battle worth hundreds of thousands of dollars to get them the right treatment. So I'm curious, first of all, do you have any practical tips and tricks for those of us trying to get our patients on these drugs? And second of all, are there equity barriers that we're facing where certain groups of the population are being disadvantaged with respect to access to the medications?
I think it's a really important question. First thing is you should demand that your institution gets you some support and a specialty pharmacy. This is not manageable by a busy clinician who's going to see lots of folks. It takes too much time, but our pharmacy colleagues do great work. And, when I first started doing this, I would literally invite every patient back every month until they got drug. We're much more successful nowadays, though there are a few people that you're seeing month in and month out for 6 or 8 months, and literally their insurances, either because they're small self-insured funds or other, aren't going to approve it. So you have to dog it. Personally, I think that ironically, the majority of people who are delayed are people with lower health literacy, don't access things well, don't fill out the paperwork, but ultimately pay nothing for it. And so I would personally advocate for a system where if someone lived in an area where we knew that the median income was such that no one's going to ever be afford these drugs at all, that they just look at their zip code and say, yep, you can have the drug, and just give it to them. They ultimately give it to them for free anyway. But we've shown in analysis we did that unfortunately it's about 3 times as long for those patients who live in low socioeconomic areas to get access to drug, even though ultimately they're not paying a penny for it.
Dr. Kittleson, would you like to add anything to that?
Yeah, it's just what Matt said. It's we have one nurse in our clinic whose basically only job is to get people TTR medications or mavacamten, which is a whole nother story, right? But it takes so much to do. And that gets to what I think are the 4 reasons you should refer a patient to an amyloid tertiary quaternary care center. And one of them is because prescription of these medications can be complicated, and it's hard to have the nursing pharmacy administrative support to push the paperwork forward. And listen, there's no shame to refer just for that reason. That happens all the time. Second is if the diagnosis is uncertain, like you're just not sure about this monoclonal protein screen, or you got a wonky PYP result back and you just don't know what it means, please refer. Other reason would be you want access to clinical trials, which they will have at the big centers. And then the last reason would be if you think they're that magical window of sick enough for heart transplant, but actually well enough otherwise. So, but the most common reason might be just it's hard to prescribe these meds, and we have sometimes can have more support in an amyloid center.
You bring up another question. Oh, I'm sorry, Dr. Coley, go ahead.
I was going to say, I'm going to put in a quick plug for the VA. If you have any veterans, send them to us because we can get tafamidis at least, and we're working on the other meds pretty easily for our veterans. The hospital doesn't love it, but the vet pays, I think it's like a maximum of $20 or something a month. So keep that in mind for your patients who might have access to that particular resource.
That's an incredibly important point. I just have a guy who's been on tafamidis for years, forgot to renew his insurance, and he informed me that he was a veteran and got drug, which we were futzing around with for a while. So very important point.
One other question I wanted to ask about access that Michelle alluded to is that referring patients to specialty centers is something that, depending on where you are, is easier or harder to do. And also likely over the next 5, 10, 15 years, we're going to be having more and more and more patients that we diagnose earlier and earlier with TTR amyloid. To what extent do you see this as a condition that can be managed by general cardiologists, and to what extent do you see this as a condition that requires referral to a specialist?
So I'm going to make a plug for general cardiologists everywhere. I think we're all general cardiologists first and maybe specialists second. This is not group 1 pulmonary arterial hypertension, which is like uninterpretable and unintelligible to even people who are supposed to know about it like me. This is a straightforward condition with a very reasonable, straightforward diagnostic algorithm and treatment algorithm thus far. So really, I would empower anyone who sees a patient with dyspnea and edema, ejection fractions typically 40-45% or higher, older, and other these musculoskeletal complaints to dive in to the ACC Expert Consensus Decision Pathway Document 2023 to go through that diagnostic algorithm. It is very straightforward, and then pick whichever therapy works for your patient based on all the caveats we've discussed. So then the next question, of course, would be guideline-directed medical therapy. We know these patients are very intolerant of vasodilators and beta blockers because of their restrictive physiology. They have a fixed stroke volume. If you have a fixed stroke volume, you can't improve it in response to afterload reduction, so often you get symptomatic orthostasis. And also, you don't typically tolerate beta blockers if you're truly restricted because you're so dependent on heart rate. So you may try them, but a low threshold to back off on those agents if your patients have worsening exertional symptoms or symptomatic orthostasis. The two medications of which we have some evidence that there could be benefit is, like with garden variety HFpEF, mineralocorticoid antagonists, and SGLT2 inhibitors. So diuretics, flexibility based on symptoms, high priority to spend your blood pressure, kidney function on MRA SGLT2 inhibitor, lower priority for the ARNI-ACE, ARB, and beta blockers.
Yeah, I completely agree with Michelle on everything. I would note, I don't think this is even a rare disease. So your comments about explosion of diagnoses are about to be seen. I mean, the fastest growing segment in the worldwide population are people over the age of 75, and that's the people who are going to have this condition. So I think every cardiologist needs to be aware of this and will ultimately be taking care of people with it. And if you think you've never seen it, the answer is you probably missed it.
All right. One more question I had on the slide, which is, I'll direct to you, Dr. Maurer. Are there any trials that are planned that are combining these therapies? We had some patients in the Vutrisiran trial who happened to be on tafamidis, but that was not part of the protocol as far as I'm aware. Is there anything that's specifically planned to investigate combination therapy versus monotherapy?
Yeah, it's a great
Maybe you're not allowed
question.
to tell us that. I don't know.
It is a question patients ask. Some people are asking for combination treatment. I think we should tread cautiously. I don't mean to focus completely on cost, but now we're going to spend, upwards of $1 million a year on someone for 2 therapies. We should be a little cost conscious that we don't have any evidence should be combined. So, the short answer is there's no planned trial to compare a drug to another, or in a class or in cross classes, or combining them directly. To be frank, pharmaceutical companies are not terribly interested in doing that. They can spend a lot more time marketing to you with probably less than adequate data and try to convince you they're superior in some regard. If we really had good evidence, we probably would have done those things. The one trial that may address this is the Cardio Transform trial, which is studying a commercially now available silencer called Aplenitersen or Wainua, which is approved for variant disease with polyneuropathy, but not yet cardiomyopathy. The trial involves more than 1,400 patients fully enrolled, and will report out next year, but the expectations are at least 70%, so upwards of 1,000 people will be on a combination treatment potentially, or on tafamidis, excuse me, as background. And so we will have, 500 people in each arm, probably, maybe enough power, though may not be. Remember, the event rates are declining, and so trying to show a statistically significant signal on top of what are already 3 very effective drugs in isolation is hard to do. So I'm not sure we're going to solve that problem anytime soon.
All right. Thank you very much. So now we'll turn to the chat. Interestingly, a lot of the questions that have come up in the chat, you guys have answered already, but I'll try to draw your attention to some. So one of the questions that came up was if there are patients with low prealbumin levels, like, for example, our old surgical colleagues may have told us about indicating malnutrition. Is there ever a sense to evaluate, a reason to think that that is an indicator of occult amyloidosis and that we should be screening people for amyloid who have low prealbumin or low TTR?
It's a good question. I mean, the people who've done the most work in this arena are the Danish, where they have a national health system, and they've shown that, in national samples where TTR has been measured in tens, if not hundreds of thousands of people, there's strong signals of low TTR levels being associated with the orthopedic manifestations and then cardiac manifestations, atrial fibrillation, and probably ultimately TTR amyloid. I'm not sure we should be widely screening everyone in that particular regard. I think we probably have enough people to screen, but it should certainly, I think, as a good clinician, raise your suspicion of the diagnosis if someone fortuitously measured a prealbumin level. They weren't on a silencer and the levels were low and they otherwise look okay. I would think they probably have variant disease, but yeah.
Great. Another question that came up in the chat, can you use these therapies before someone develops heart failure? To the best of my knowledge, none of the trials look specifically at that, but I'm curious, do you think there is a world in which we may be screening people for subclinical manifestations based on, imaging findings alone or something like that? Is that something people talk about? Is that something people are interested in?
Yeah, I mean, we're doing that a little bit in some studies that we're doing, active ascertainment programs in people, for example, who have these orthopedic manifestations, particularly lumbar spinal stenosis and carpal tunnel. Michelle and I are part of a NIH-funded study in which we're calling back people who had lumbar spinal surgery from 10, 15 years ago, who had stored samples at Cedars, Columbia, and 3 other centers. Turns out that, at least at this point, almost half the patients have amyloid in their spine. And so you wonder if they're not going to develop amyloid in the future. Again, the Danish group has shown in a paper in JACC that, about, not a high percentage, 5 or 6% overall post carpal tunnel surgery. But if you're a man over 70 with previous bilateral carpal tunnel and you're not obese, it was like 1 in 4, 1 in 5 could have amyloid many years later. So people are thinking about that. They have to have cardiac amyloid, which means they have to have a positive scintigraphy, I think, to treat them. If you don't have cardiac amyloid, these drugs aren't indicated. I don't think we should prescribe them. The off-label thing you could give them if they really have no heart failure syndrome, they have no contraindications, is diflunisal, which is a non-steroidal that probably works almost as well as all the other stabilizers, but is relatively contraindicated in people with established heart disease.
Dr. Kittleson?
I was going to say the other population that actually becomes very important, and then this also gets to a question in the chat. So efficient, I'm going to say 2 things to kill 2 birds with 1 stone. It's not just this, who do you survey for the development of cardiac involvement? So it's those people who have unanticipated, incidental TTR amyloid in their carpal tunnel specimen after surgery or their spinal surgery, because now hand surgeons have a heightened awareness, and at many centers will just send it to pathologists for staining. And then you're going to follow them, track them serially for the development of potential cardiac involvement. And it's also those patients, V142I being the most common in the United States, 3.4% of Black Americans. So everyone should get genetic testing when they're diagnosed with cardiac amyloidosis. And the most important reason really is cascade screening of first-degree relatives. But it becomes a bit of a tricky thing, because if you're 30 and all of a sudden you find you have a V142I variant, it probably doesn't matter for another 30 years at most. So what do we do with those people? So typically you will start screening someone who's an asymptomatic gene carrier about 10 years before their affected relative was diagnosed, assuming that there's going to be some delay because of lack of recognition. And how will you screen them? Typically, it'll be with things like biomarkers and echocardiogram to start. So if they're high sensitive troponin, NT-proBNP, or echo shows any abnormality of global longitudinal strain or LV wall thickness, then you can say, I have a high suspicion, let's put you through a bone scintigraphy scan. But that gets to the point where those patients who might still be minimally symptomatic, but have some evidence of cardiac involvement, you would initiate therapy. But as Matt said, you would not in the person who just had in a carpal tunnel or a lumbar spinal specimen with no evidence of cardiac disease.
And just two other things to add. One is a concern, which is, we're using scintigraphy to diagnose people. It's very specific in the context, as Michelle said, of no monoclonal proteins. That's key, right? If you have uptake that's grade 2 or 3, confirmed by SPECT or SPECT-CT, that's the disease. We're 100% sure. It's not very sensitive, guys. It's actually, in the seminal papers, got a sensitivity at amyloid centers with advanced phenotypes of about 70%. So you just fast forward now you're screening a patient, you're thinking they could have amyloid, and you may have a screening test that doesn't have a high sensitivity. So I often say to patients, you don't have amyloid, but I add the word yet, right? Because I think, many of these patients, the allele carriers, the people with orthopedic manifestations, need to be, if we're going to do it, in a screening program. Back to treatment, there is a trial that is being run for Acoramidis as a prevention trial in allele carriers. So if patients are within 10 years of what the predicted age of disease onset is when their relatives would develop disease, they can be enrolled. It's a randomized trial testing whether or not we could prevent the development of disease with a stabilizer.
One quick question as a piggyback about genetic testing. Other than affecting cascade screening, does genetic testing affect how you think about which treatments to use for a particular patient? I'm not aware of any data that shows that it affects that, but I'm curious, practically does it?
In the past, it did, because we selected agents on the basis of whether someone had variant disease and potentially a neuropathic, but I think that's less important. Obviously, there are certain variants that are highly associated with a neuropathic phenotype, and you probably spend more attention in that. Particularly, the third most common in the US is the Val30 MET mutation. Second most common is the so-called Appalachian or THR60 ALA. Both of those have a pretty significant neuropathy component, and particularly autonomic neuropathy. So when you're seeing those patients, you want to kind of delve in a little bit. They have very subtle symptoms, but I don't think at this point anyone's picking an agent on the basis of that.
Great. We are just about at the end of our time, so I think we're probably going to have to wrap up there. Thank you, everybody, for your participation. Thank you, Dr. Maurer and Dr. Kittleson. It's been a great session hearing from you, and thank you, Dr. Coley, for helping us put together everything. For those who are interested, this session is recorded, and so it will be available on our JACC Journal Club website afterward. And pay attention to your emails. There's more JACC Journal Club sessions coming over the coming months and coming years. So thank you guys again very much for participating.